This is Lichaa, interventional cardiovascular specialist, coming to you with a quick video on the importance of identification of the inguinal ligament by ultrasound to avoid high sticks in common femoral artery ultrasound guided access. As you see here, the operator is sweeping the groin up north towards the external iliac artery, identifying the common femoral artery first, and then sweeping to the external iliac artery. Ultrasound is excellent at identification of the common femoral artery bifurcation and how to avoid low sticks. However, best access practices usually incorporate fluoroscopy with ultrasound in order to avoid high sticks. And this is sometimes not possible with ECMO cannulation in a sick patient at the bedside or arterial line placement in the ICU. As you see here, just plain ultrasound guidance sometimes can lead to high sticks, and which takes us back to basic anatomy. And most invasive cardiovascular specialists are trained to identify the mid-femoral head and to stick right below the mid-femoral head. This is usually done by fluoroscopy, by placing the hemostat and performing 1 second of fluoroscopy to identify that, marking that area, and proceeding with entering the skin at a site that takes into account the thickness of the pannus and the anatomy of the patient. Now, what about CCU bedside cannulation, where fluoroscopy is not available? So the inguinal ligament separates the groin from the pelvic area, and it's important to identify this inguinal ligament by ultrasound when fluoroscopy is not available, with this longitudinal hyperechoic structure above the common femoral artery that prevents sticking into the pelvis. And in order to identify the no-stick zone, the operator can either just sweep the ultrasound in a perpendicular fashion to the skin north or south, or sweep it by angulating the tail of the ultrasound probe. As you can see here, this is the inguinal ligament that has to be identified. Then the operator is sweeping from the common femoral artery to the pelvis, and where you see the inferior epigastric artery appear, and this is where the nadir of this artery defines the lower edge of the pelvic floor. Very important not only to identify the inguinal ligament, but also the inferior epigastric artery. When the operator is in the cath lab, this is followed by the mandatory fluoroscopy of the needle wire transition to make sure it's at the mid or lower than the mid-femoral head. And as you see here, the no-stick zone is identified by the nadir of the inferior epigastric artery, and the stick was below it.